When the hospital is hours away and every second counts, master the art of survival. This is Survival Medic.
Welcome back. In this video, we will discuss challenges that are unique to wilderness medicine. First, the term wilderness medicine has typically been applied to instances in which definitive care is more than an hour away. Definitive care is defined as the hospital or clinic where a patient can be evaluated, diagnosed, and treated. The definition of wilderness medicine has also been expanded to include prevention, diagnosis, and treatment of conditions in extreme environments, such as deserts, high altitudes, or aquatic environments. Practitioners of wilderness medicine are also trained to provide care in environments with limited resources and/or limited ability to communicate with outside assistance. The combination of limited resources, difficult communication, and remoteness means that rescuers in the wilderness have to make decisions and use techniques that are beyond what is expected of caregivers in urban settings. Care in the wilderness focuses on stabilizing a patient's injury or illness to minimize their chance of death or disability and to improve long-term outcomes. This is focused upon instances where help from outside assistance will be delayed by distance, terrain, or weather. Caregivers in the wilderness must be able to recognize when evacuation is necessary. Rapid evacuation is necessary when there are life or limb-threatening injuries. If a patient is unable to travel quickly to medical care on their own, then outside sources may need to coordinate an evacuation. This may include instances when rescue by helicopter is needed. Otherwise, for non-threatening injuries that are not able to be managed in the wilderness or backcountry, evacuation is advised to occur as soon as possible, but without immediate assistance from outside help. Lastly, there are key differences between the care that is provided in urban settings compared to wilderness settings. These differences are seen in transportation time, communication or notification time, resource availability, duration of care, decision-making, and environmental dangers. When emergency medical services, or EMS, are called to bring a patient to the hospital, they rarely have to choose between transporting a patient or not. Instead, they simply opt for transport and let providers at the hospital make further decisions. However, a wilderness provider may be required to care for a patient for hours to days before they are able to reach definitive medical care. During this time, communication with outside assistance will be dependent on the tools that you have available and location. If providers only have a cell phone available, but they are too far in the backcountry to receive reception, then caregivers will have to make decisions on their own, unlike EMS, who have contact with other health providers. The harsh environment of the wilderness and limited resources is another factor that providers must account for within this specialty. We're at the end of Course 1, and we have our guest speaker, Dr. Angela Wright. In this lesson, we're going to present a wilderness medicine scenario, and we'll interview Dr. Wright on how she would assess, treat, and produce a plan for the patient. Dr. Wright is an emergency room physician who specializes in emergency medicine and specifically in the training of EMTs and paramedics. EMT stands for Emergency Medical Technician. This is our scenario. Isaac was free climbing in Colorado with his two other friends. Free climbing is a form of rock climbing where the climber does not use the usual protective equipment. This includes ropes, carabiners, or other tools to protect against injury in the case of a fall. He was about 10 feet up the rock face when he slipped and fell to the ground, landing flat on his back. Isaac immediately felt a sharp pain in his neck and upper back when he landed on the ground. Isaac's two friends immediately rushed over to him and asked him what hurts. Isaac replies that he has sharp pain in his neck and back. Dr. Wright, it's really great to have you here. What would be your initial concern?
Thank you for having me. Initially, it's important to ensure that you as a provider are safe before you go in to try to help somebody else. If you're confident that you yourself won't fall or be exposed to a rock fall from above, then I'd feel comfortable approaching the patient and continuing my assessment. Given the fall, a mechanism like this could be concerning for a variety of injuries. I would specifically be concerned, however, for a spinal injury. I like to approach all trauma the same way and in a very systematic way. Conveniently, the acronym for this is very simple: A, B, C, D, E. So in this patient, my initial concerns are going to be on the A, B, C's: airway, breathing, and circulation. Once I have determined that these are intact, I would be focused on the D for disability, especially in this patient. I'd want to do an assessment of his neurologic status by assessing his strength and sensation in all of his extremities. The combination of the fall height with his complaint of neck and back pain would make me specifically concerned for an injury. Thus, I would want to make sure that, if I have the resources, someone stabilizes Isaac's head and neck before we move on. I think at this point, if there is concern for a spinal cord injury or a spinal fracture, I assume that one exists, and from this moment forward, I will be taking the precautions and doing the appropriate things in order to protect the spine.
Isaac's friends now perform a secondary assessment. On his head-to-toe physical examination, they find that Isaac has pain with palpation of the neck and upper back over the spine. They decide to perform a spinal cord assessment. Dr. Wright, how do you perform a full spinal cord assessment, and what things are you looking for that would be concerning?
There are a few key components to the full neurologic exam or spinal cord assessment, which is part of the neurologic exam as a whole. The first two things to evaluate for are altered mental status, or a patient that isn't with it, and if a distracting injury is present. For example, if someone's femur is sticking out of their skin, any additional answers to attempt to assess about the spinal cord or other areas of pain are going to be unreliable, because their body may be tricking them or distracting them into thinking the only thing that's wrong is their femur. If the patient is awake and alert and doesn't have any obvious distracting injuries, then our spinal cord assessment and the rest of our neurologic exam is likely to be reliable. If your patient meets these criteria and can slowly move their neck from side to side and up and down with no pain, and they have no pain upon palpation of the neck, then you don't need to apply a C-collar. However, if they do have a distracting injury or they are altered, then you must assume they have an injury and spinal motion restriction measures must be taken. With precautions in place, there are a few questions to start with. First, is there midline pain or pain along the spine? Next, can the patient move all extremities equally and normally? It is okay to have them move their arms and legs carefully and evaluate for major differences between the two sides. Then, can they feel everything? Gently touch their arms and legs at the same time and ask the patient if it feels the same on both sides. Do you see why it's important to have a patient that isn't altered? They need to be able to answer all these questions. If you notice any differences in their movement or sensation in your exam and you haven't already, then it's important now to put on a C-collar and apply spinal motion restriction.
On the full spinal cord assessment, they find that Isaac is alert and oriented. His neurologic exam is intact. However, he does have pain with palpation of the neck, the spine, and pain with movement of his neck. What would you do to treat Isaac?
In this situation, since he does have pain in his neck, I would make sure that I try to immobilize his cervical spine the best I can. Ideally, this is with a C-collar, but also since he's awake and alert, reminding Isaac repeatedly not to move his head is also important. If there's no C-collar available, then I would see if there was a blanket roll or bulky clothing or something I could use to keep his neck still and limit extreme ranges of motion. Even if it isn't the most effective splint, the act of just having something there to remind him to keep his head still is important. I would check his neuro exam before placement and after placement of the splint and periodically reevaluate him.
What would be your plan to get Isaac to definitive care?
Given that we are concerned about a spinal cord injury, Isaac will need to be evacuated and evaluated. and given our concerns, he cannot walk. Thus, we will have to come up with a safe evacuation plan for him while maintaining spinal cord motion restriction as best we can. In Colorado and in many other places in the world, there are several search and rescue teams that could help. We could consider flying him out with a helicopter or utilizing other resources to get him to a place where we can safely evaluate him.
Why is evacuation necessary?
So, injuries to the spinal cord can be permanently disabling or even life-threatening. Thus, we need to get him to an emergency room as quickly as possible for further diagnosis and treatment of his potential injuries. We want to minimize any additional trauma or injuries that may occur, and walking with a spinal cord injury can significantly worsen the situation. It is not safe to walk someone in a C-collar. Given his fall and exam findings, he needs to be evacuated safely and will require a workup, medications, and potentially even operative care in order to provide definitive management. None of these things can occur in the wilderness, unfortunately.
Be prepared for the unexpected. Get your copy of Wilderness First Aid on Amazon today. Link in the description.